GPA. So I think we introduce ourselves and then we'll get right into it. So I'm still Peter Merkel from the, Dr. Peter Merkel from the University of Pennsylvania. I've been studying vasculitis for 25 to 30 years, and we run our vasculitis program there, and I run international trials and been involved in development of many of the medications that we use now through the Vasculitis Clinical Research Consortium that I lead and work with industry, et cetera. And I'm a rheumatologist.
I'm Alvise Berti. I'm working in Italy, up north. And I work in the rheumatology department of the University of Trento. I'm doing clinical and translational research in vasculitis.
And then I'm Andy Stein. I'm a laryngologist at Northwestern, just here in Chicago. And a large part of my practice is managing patients that have subglottic or tracheal stenosis. So a large number of our patients have GPA or some other sort of vasculitis condition.
So we're looking for questions. Maybe it would be good for me just to remind you, in the absence of slides, that from the time that I was a rheumatology fellow at Boston MGH in the last century to now, we've had remarkable change in the treatment and the approach to patients with granulomatosis with polyangiitis. First of all, we called it a different disease then, which we don't call it anymore. So we changed the name of the disease and we changed our therapies. Back then we used an enormous amount of cyclophosphamide to induce remission. And that was a major, major advance. Prior to use of cyclophosphamide, people died all the time. It was terrible. I got to start after that was done, and that, of course, was done by the champion by none other than Dr. Anthony Fauci, who really made that happen at the National Institutes of Health. It's a kind of remarkable story. Before he got involved with all those other little things like HIV and COVID and everything else he's done for the last amazing career. So we then moved on to be using methotrexate, and we used more azathioprine and other medications after rituximab. So you start rituximab, and then you go to kinder and gentler drugs, and sometimes we used other ones. And then we did the studies of rituximab, which led to its approval here and around the world. And the rituximab story has been great. Probably now, at this point in the United States, probably 80 to 90% or more of patients with new onset disease are put on rituximab, and even more with relapsing disease. And that's around the world. It's varying based on availability and because of the costs. Well, that's gone down. And then we have had trials where we've been able to show the reduction in the use of glucocorticoids, prednisone, everyone's favorite drug. We've been able to reduce those through data that really supported it. And then we've been able to do the newer drug Avocopan, and I was very much involved in that development, and that's been an oral drug to add to other therapies to allow people to come off glucocorticoids. All along the way, we understood the disease much better. We have data to drive our decisions about where to go, but those data end quickly with the individual in front of you. Not everybody fits that exactly. And we've gotten better at treating the subglottic stenosis and some of these other areas because of experience and teamwork. So the treatment landscape is different. This is a disease that has become, hopefully at best, it's a one-time you get rid of it. That's unfortunately not the norm for granulomatosis polyangiitis, very much not. But it was a very severely mortal disease that killed a lot of people to a chronic relapsing disease, which is a happy problem. This is a good thing that it's become that because the alternative was bad. We still need to cure it. So just to give you that landscape, as we've come a long way, but we have a long way to go to make it better for everybody as well. And so we're here not just about treatment. We're happy to talk about new ideas, research, and individual manifestations. So with that intro, is that okay? You want to add?
Yeah. No.
We'll sort of go from there. Great progress, more to go, and that's all good if it helps the individual in front of you, which is what we try to do. So questions? Don't be shy. Here we go. Can you come to a microphone? Or can we get a microphone to her? Hold on, it's coming.
Oh yeah, good, okay, pass them around. So in your practice with your GPA patients, there's some papers that say you do the induction, and then every 6 months or 4 months or whatever, you dose those people regularly. Then there were some studies done out of, I think, France that said more tested on demand, right? So you're looking for specific markers. What do you do? And what markers do you look at so that you make those decisions?
So thank you for the question. That's we have actually, as you mentioned, there are evidence now that rituximab, which is that one of those drugs that Peter Merkel was mentioning before, is really effective on the disease. So we just don't use it for induction, but also for maintenance of the disease. GPA as MPA we treat them, we manage them in two phases. One is induction and the other one is maintenance. So a low dose of rituximab has been proven to be better than other agents. Sorry about it.
No, just the wrong slides were brought up.
Okay. Better than other drugs. And so that's why there are these papers that testify that it's good, and we started to use it often and more often. Which kind of scheme do you use? It depends probably from the patients first. Not every patient is the same, so we have guidelines, we have recommendations that suggest us how we should manage patients in certain situation, but it doesn't really mean that same treatment is good for everybody. So to make a long story short, we use more and more rituximab for maintenance. We decided if rituximab is better than others depending on the single patients, and then the local practice also makes some difference. I'm practicing in Europe, so that's difference probably as compared to US. We do, for instance, in my center, we try to use more and more rituximab, 500 milligrams every 6 months for maintenance, fixed dose, but I still have some patients that do the on-demand dose. During COVID, we switched on the on-demand dose, which means when the B cells come back, we treat the patient again in order to reduce the dose of therapy that the patient received. That's good, actually, and especially during COVID, that, as you know, has been caused a lot of issues and a lot of morbidity in patients with vasculitis. That probably it was better to try to reduce the dose of rituximab and to find out some window to get vaccinated for patients. So, but it really depends from the patient. That's what I wanted to say. It's not proven, as you mentioned, and I leave Peter Merkel add. I don't know if you have to ask something or not, but
Always.
But it really depends from the patient.
So I think I actually agree with everything you said. I think the practice is very similar. I want to get back to your specific question as well, but just to perhaps reiterate, we think of therapy as induction. Think of that as the upfront when it's acute. It's putting out the fire, right? So the inflammation is happening, this fire is happening, if you will. We want to put out the fire right away. That's nice, but there's still embers. There's still things that be glowing, and that's going to come back up. And so how do you keep it down? And so much as in cancer, you give high-dose chemotherapy sometimes for some cancers, and then you give something else to keep things away. Those can be sometimes other forms of chemotherapy or something else. We're thinking the same way in vasculitis, this autoimmune disease. Tamp the immune system down. It's the Goldilocks principle. You want to lower the immune system enough, but not too much. You go too much, you're at risk for infection. Not enough, the disease comes back. So we're going to lower the immune system with induction and then keep you there with maintenance. Back when, in the olden days, we had a much longer period of induction, and now we have shortened it because we can get away with it better, hard hit up front, and now longer, and then we used to have maintenance for shorter periods. Now we have years and years because the risk of relapse is so high. With rituximab, the drug lasts for months and months. We also use 500 every 6 months as maintenance, except when we don't. And when don't we? Well, one thing is not every human is the same size, and so it probably matters how much you give in terms of how effective it is. Some patients break through at 500, so we give them 1,000, then we go to 750. Over time, we adjust. But we try to go to high dose up front and then lower dose. Your question was, Should we be measuring the B cells? So B cells are a type of immune cell, white blood cell. Rituximab does more or less one thing. It kills these B cells. It's good at it. It's not perfect at it. There's still B cells lying around that aren't done in the tissues, et cetera, which is why we're looking at some new things. And I'm going to mention that later because someone asked me to. But it's really good at it and clears it out of the blood, but then they come back. And so we want to get rid of those. And when you do that, you also lower immunoglobulin levels and other things, and it puts you at some risk for infections. There's a question of whether or not, French showed a study where you could wait for the B cells to come back, maybe with the ANCA, and then you dose and you can get away with less Ritux. They're actually now saying don't do that. So the French have now come back with follow-on data and said, oh, you know what, we actually not so sure that's a great idea because people are relapsing and it's not really saving that much. So there's some centers that will try to do that. We don't. I don't think the data is there to support that. But so I think it's a lot of just doing, we also delayed it to some extent during COVID. It really depends on the situation. The problem is it ain't good to have your GPA come back. Sometimes it's just a little bad, sometimes it's badder than that. And what you really don't want to have to do is go back on prednisone. And so now a little bit, okay. Short term, maybe okay. Maybe you won't hit me for that. Heavy doses, again, not so good. And so we have to balance those risks. And that's what we're trying to get at. And so I think that's what we do. Now, should every patient be on chronic recurrent disease, rituximab? Many people are, and we're trying to figure out, we're actually doing research to try to figure out who can we stop. So we often talk about who needs more. Here's a question, who can we stop? And we're trying to figure out markers and data to help drive those decisions. Many people will say, I've had enough of meds, I want to stop. The most important thing is to be followed very carefully. I want to make that very clear, and I want to know your points as well, whether it be subglottic disease, Angel's disease, anything. On treatment or off treatment, you need to be followed very carefully by your physician and by yourself. You are the early warning system. If you think there's a problem, you got to let us know. You'll know if there's something new. As a matter of fact, when we stop therapy, we monitor people even more than we do when they're on therapy because we don't want to miss the recurrence. I don't know if you each want to talk about that. And that's true for ENT disease too. It's true for what you do down in the larynx.
Yeah, so is mine working? Oh, yeah. No. So, yeah, just to piggyback off of that a little bit in terms of, following patients closely. So in terms of what I do, managing subglottic and tracheal stenosis. So a couple things about that. One, what we're kind of talking about, when someone has an acute flare of GPA and if they have subglottic or tracheal involvement, that's usually not the time that we would talk about going to the operating room to intervene on the airway, because then you're intervening at a time that the airway is really inflamed, and potentially you take someone with a problem and then you could make it worse with that intervention. So usually a lot of those times, at least for me, I talked to Dr. Duo, who's kind of my partner from the rheumatology perspective at Northwestern, and we really want to control that person's systemic disease first. And then when that systemic process is controlled and we feel like the airway is not acutely inflamed, then often you're left with some residual scar tissue in the airway, and then that's a time that we can go safely to the operating room and intervene on the airway. We usually give the patient some steroids before and after surgery just as an extra measure. But that's kind of a big thing, is sometimes people will see someone that has an acute narrowing of the airway, and you have to figure out what's the cause for that. So if they didn't have a carrier diagnosis of GPA or vasculitis or something, that has to be worked out before you just rush that person in the operating room and try to intervene on their airway. The other thing about that part of things is, especially from my perspective, whenever I meet someone for the first time, I try to evaluate their whole airway, whether that's an awake bronchoscopy in the office, or if they're unable to tolerate that, then doing a CT scan that goes, from the neck all the way down to the chest, because especially patients with vasculitis, they can have multiple areas of their airway that are narrow. So if you go to the operating room and you're thinking it's just going to be the subglottis, which is the most common area, and that's just below the vocal folds, and then they have something further down and that wasn't recognized, then that again can lead to a significant problem. So a lot of times we partner with myself and with interventional pulmonary if the person has airway stenosis kind of in 2 sites to make sure that everything's managed all at once. And then to get more to Dr. Merkel's point about careful follow-up, usually, if we do an intervention for someone's airway, then we give them adjuvant medications afterwards. So usually I have them do nebulizer treatments with a steroid and antibiotic for a period of time. And I see them at a month and then kind of gradually out from that. And then if people do really well and they've gone like a year without an intervention, then usually we see them every 6 to 12 months, but always at some sort of regular interval. And then one thing from an airway perspective is I always give patients something called a peak flow meter. So they can, it's at least one objective measure on how quickly can they breathe out, which will give some indication on what is the level of narrowing within the airway. But just like Dr. Merkel said, if I see someone, they're doing great, and I say, okay, come back in 6 months, but please let me know if anything comes up before then we always, get people in sooner if they start to sense that things are worsening.
So we found the slides. So, and I'm now almost a little nervous about whether but we're going to do them anyway. And I'm sorry I didn't have Dr. Stein's name on it because the version I had of the program, you were not there, sir, but we're very glad you're there. So I'm going to go rapid fire here to set us up again, recognizing that it's a lot of information. Just to remind you where you are in the tree here, the tree of vasculitis life. The granulomatosis with polyangiitis is one of the ANCA-associated vasculitis. We try to make things as complicated as possible. So it's one of the 3 types of ANCA-associated vasculitis, along with microscopic polyangiitis, or MPA, and eosinophilic granulomatosis with polyangiitis, because I get to say it fast, or EGPA. And that's part of small vessel vasculitis. And then there's other types. So it's good to see that this is the family of vasculitides. You don't get to choose whether you're in this family or not. It chooses you. And but that's why we're all talking about here. So put it into sense. This is just to remind you and remind us to remind you, this is a very busy disease. This is a disease that can affect many different parts of your body. And this is a list. It's not even a full list because lots of things happen. Fortunately, not everybody gets all of this, but everybody gets some of this. And if you relapse, you can get other stuff. We actually published some data demonstrating that a large percentage of patients actually, over the course, will develop problems that they didn't have when they first presented. It's good for you to remember that because people said, oh, it's not just that stuff. So that's why we look everywhere, and we're happy when we don't see it. Lots of upper airway, lower airway, and the kidneys, nerves, joints, feeling fatigued. That's all real. That's part of your disease. Eye disease, skin disease, vascular problems. Rare, fortunately, the heart's not often affected, although we think that patients over time could have more heart disease if they don't have their disease controlled. Rare GI, and of course, lab findings. It's a complicated disease, lots of different things, but it's good to know that. This is another version of that Dr. Berti added. You can see that its different organs have very different percentages of involvement. There's lots of kidney disease, lots of lung disease, not as much some of the other problems, not as much brain disease, et cetera, for example. And there's a difference between granulomatosis and microscopic polyangiitis. At least we make that differentiation. Sometimes it's hard to tell those, and we study them often together. Similarly, this is a nice cartoon of some of the differences, and we often talk about non-severe disease, severe disease, other disease, and we talk about the ANCA type that you have, which is PR3 or MPO. You might have, in the old days, we might have talked about C versus P ANCA, but we're trying to get away from that and really more talk about these other things. And they are different. Why do we bring that up? Because we're getting smarter and we're treating patients differently based on which of these they have. Someone who has MPO first time, much less likely to relapse than PR3. And so we may have different decisions that we make when we're in the office together. And finally, to remind you, I think I said this yesterday, it seems like long ago, yesterday, that the Vasculitis Foundation partnered with the American College of Rheumatology, and we have these guidelines we put out that are helpful. They're not absolute rules, but they're helpful, and you may or may not want to look through those. They're available on, I don't know if they're on the VF website, they're certainly they are on the VF website, and they can be helpful for you to get a sense of. Again, they're not an absolute playbook. You don't just order these drugs on Amazon and then start doing it, at least not yet, and I hope not. But these are guidelines to think about. These are some European guidelines that actually Dr. Bertie and I were both part of as well, as part of the other ones as well. And they're very similar. They're thinking about how to do this. And so these are nice that there's something. This is a busy slide that shows you, look at all these options. We can use methotrexate or rituximab for what we call non-severe disease, meaning it's not organ threatening right away. And then what do you do afterwards? You see the induction and remission phase. And then down below, what do you do with more severe disease? Really, it's cyclophosphamide or rituximab, and then this new drug, Avocopan. So cyclophosphamide known as Cytoxan, rituximab, Rituxan. I like to use the chemical names, but this and Avocopan is Tavneos. And so you can see that we have choices. We had none of these choices. We had one drug up there when I started. We had cyclophosphamide. So I want to make it clear there's been progress and there's options that are great. And so, but we still have more to do. And so I hope that's helpful and not confusing. You can say, well, I haven't been on all of those. Good, good. Who the hell wants to be on all those drugs? Probably on some of them. And so that's not a big list, but it's bigger than it was. And we're still looking for ways, and we've done well in strategies to reduce prednisone. So with that background, let's take some more questions. All right.
I have two, and Glenn beside me has one. My first one is in the literature, there's been some discussion about for subglottic and tracheal GPA, about the use of Bactrim. Can you educate us on that, please?
Like, so prophylactic Bactrim, you're saying,
Right,
for subglottic tracheal stenosis. So part of that, I'll say, is that I think, let me back up a little bit. So at the Mayo Clinic, for example, so patients that have what's called idiopathic subglottic stenosis, they will treat all of those patients. They'll do surgery, and they'll treat all of them indefinitely with Bactrim, PPIs, and then an inhaled steroid. Okay, and then that's a totally different disease process though than GPA. And they did show maybe over time that, you know, their patients had a longer intersurgical interval than maybe, you know, the average patient or the average center, depending on their comparison. I don't know that the reality is I'm not sure that the evidence is that strong that like Bactrim alone or the PPI alone or the inhaled steroid alone is beneficial, or was it that also the surgical approach that they use is slightly different than just putting a balloon in and stretching, for example. And then there's a whole slew of different interventions that people use. So for example, I tend to use more of the like excision of the stenosis with a laser and then injecting steroids and then gently dilating with a balloon. That's kind of similar to what they do at the Mayo Clinic too. So I don't know if that totally answers your question. I would say I don't know that that information has been completely isolated, but I think for these disease processes, people just, I think sometimes throw whatever they can at it. And then if they start to notice, okay, some of their patients are doing a little bit better, then they'll kind of continue that. But I don't know that it's been really well researched that Bactrim alone, for example, is beneficial. And I would say I think there's just different schools of thought that some people just tend to use it, you know, off the bat for every patient. What I've, I guess, been doing sort of in my approach is sort of standard interventions to start and then more monitoring the patient, see how they do. And if they have early recurrences and things like that, then to start thinking about, are there things that we should add to the picture? Or for example, most of the time if someone has granulation tissue in the airway, which a lot of times patients with GPA will send that for culture. And so I personally believe a little more heavily in like a culture-directed antibiotic treatment for a period of time than just indefinite period of antibiotics. The other thing that I'll add to that is that more in like pediatric airway disease, I think there is a greater tendency and there's a greater belief that chronic antibiotics are beneficial in reducing the risk of restenosis. But the short answer is I don't know that there's great evidence one way or the other, but I think certain practice patterns and depending on where you were trained or just your personal experience, I think you're more likely to maybe end up at a center where they're like, part of your treatment is we're going to do a surgery and then you're going to take Bactrim and these other things indefinitely, and then other places may not necessarily adhere to that. I don't know that one is right or wrong.
So let me just
Yeah.
That's great. I'll do a little simultaneous translation. Bactrim is trimethylsulfamethoxazole. It's an antibiotic that is used. It's an old antibiotic we've used for years for various things, also known as Septra and other things. That Bactrim's a brand name. PPI is proton pump inhibitor. It's anti-acid that we use. Our ENT colleagues like to make sure that the acid doesn't come up and cause damage. I think that what you're hearing is a problem area, which is we don't have, I don't think there's any doubt that we don't have good data to support these decisions one way or the other. We don't have good data on surgical interventions. It has to do with a variety of things, and it's hard for a very rare subset of a rare disease. The reason antibiotics have been of interest is the idea that there are bugs. We all live with bugs. They're all in us and around us, and generally they're good. We're happy with them, and they're happy with us. That's what we call the microbiome. So they're all over our skin, they're in our gut, they're in our airway, and we live happily with them. There is good information, good data to say that alterations in that may affect your immune system, et cetera. And, people take probiotics and all these other things, which I would not necessarily recommend without some better data. But from various centers, including our own Rennie Ree, a former VCRC VF fellow, I might add, who is a faculty member, our place is doing some very interesting work looking at the microbiome and the change that happens when patients are in remission versus when they have active disease in the nose. Whether that will translate to the trachea, it's not clear, but there's clearly something there, and she's done some work with using TMP-sulfa-Bactrim as well. That's coming out in a different publication. So we're very interested in that idea, but right now it's whatever. I will use trimethylsulfamethoxazole or Bactrim sometimes for upper airway disease when they just can't get off those little bit of glucocorticoids, et cetera. Remember, and there's some data to support that and some that says no. Informed decision, every drug has side effects, gotta do it forward. I think more importantly is what you said is I want our patients to call us right away if they're having trouble breathing or if their voice changes or anything that changes. So it's about that communication. Do you have any comments on antibiotic use? You had another question, or someone else at your table had a question?
Yeah, we have two more at our table, please.
It's a very busy table.
It's
Some of you tables over there need to start getting on the ball here, okay?
There's one beside me too. Just, is there an updated view on Avocopan and whether it's still combined with prednisone with Ritux, or the prednisone goes away with the Avocopan and the Ritux, just what the thinking is there?
Everyone's pointing to me because I helped develop that. So Avocopan, how many people know what Avocopan is, or Tavneos? Okay, so it's not everybody. It's a pill. You take 3 pills twice a day. That's how the formulation is, and we did a big study. It blocks something called complement, C5a. Again, now we're combining words and numbers to make it even more complicated. And we trust me, the physicians get completely mixed up too. So this is a chemical that is part of the immune system, keeps skin going. And what we were able to show with a big trial, a couple of trials and then one big one, was that patients who took this were able, in addition to rituximab or cyclophosphamide, were able to get into remission, as well as people who didn't take it, but the people who took it were able to do it by stopping their prednisone by no later than 28 days, which is nice. And that if they stayed on the drug, they were more likely to stay in remission. And so we're using this drug. It's now available in the United States and various countries. I think it's available through special use in Italy. So it's because it's costly and that's still being worked out. It hasn't been that long out. We use it in many patients with new onset active severe disease. We use it for 6 to 12 months, and then the question is whether you keep going. It's not a drug you would use, I'm stuck on 10 of pred. Let's take Avocopan. That's not how it's been used. That's not what we've proven. It's for upfront when you have more significant disease. And we've been able to use it in our center the way we used it in the trial successfully. People are able to come off glucocorticoids quickly. The question you have maybe is, I'm not sure that answers your question, but about whether or not it's used with Ritux versus not. It's always used in combination with rituximab or cyclophosphamide up front. The question then becomes, if you're going to continue Avocopan or Tavneos, do you also continue rituximab? And we didn't test it that way, but what we're doing in practice is we're often giving the rituximab again, and continuing the Avocopan, and then because with those patients, we're going to do better. That's a decision we're making now. More research will come to help us make some of those things. Again, what a happy problem that we have more choices to add to our ability to get off glucocorticoids. Do you have a follow-up question? Can someone? I'll repeat the question. Yeah, when you say. So is there any data to support staying on Avocopan past 1 year? No. There's experience that we're gaining in the field, and that will be scooped up and sort of will get a sense. I can tell you what we do, and I know the data as well as anyone in the world. Sometimes we do, and sometimes we don't. How is that for a great answer? It's like I'm in front of the Senate, you know. So that's a decision we make. Sometimes the insurance companies help you make that decision because they're no longer going to pay for it. There will be follow-up research that will help address that question. Maybe we should just take another table for a moment and then go ahead.
Thank you. Thank you, panel, for taking our questions today. My question relates to ANCA-negative patients and Avocopan. We're told by a rheumatologist that Avocopan has been well studied in ANCA-positive patients, but not so much in ANCA-negative. What is the current medical thinking on the use of Avocopan in ANCA-negative patients? Thank you.
So actually, that's true. There are not a lot of data about ANCA-negative ones. So theoretically, we do not have evidence that it's really working well, but it's supposed to. At the moment, I actually, in my country, is used for only for severe cases, like it's off-label yet. It's going to be in-label very soon, so I do not have a direct experience to say that if it's working in ANCA-negative as well, but I believe so. I think so.
Yeah.
That's sure.
So this raises a great general question about ANCA-negative versus ANCA-positive patients. So the vast majority, so in GPA, when properly tested with ANCA, it's 80 to 90% of patients will be ANCA-positive, probably 90% at this point for sure, with the way we have better assays. But there are some people who are not, or negative for ANCA in the beginning. Some of them are negative later, that's a different story, but ever negative. And the question is, are they really different? Is it a different disease? Is it really a different thing? And I don't think we really know. In general, they have less severe disease. They tend to not get kidney disease. They tend to not get the bleeding in the lungs, the lung hemorrhage. And those are the things that often drive us to use the Avocopan to begin with. So that doesn't mean they can't have misery. That doesn't mean they don't have real problems, because absolutely. But I don't think we have good evidence that treatments work better one versus the other, because it's not about ANCA so much. So if I had a patient who had severe disease, who I felt had GPA but didn't test positive for ANCA, but I thought had disease, I would use Avocopan, because I think it's more likely that they are like that, those other patients. But it isn't, so I'm part of the just ask my wife, I'm part of the problem. And because we run these trials where we sometimes say, if you're ANCA-negative, you can't be in the trial. And that has to do with making sure the patients have disease that's studyable in a similar fashion. We actually just finished a trial, Dr. Langford and I just finished a trial of another drug, abatacept, which exactly for patients with more mild to moderate disease. We hope to have results later this year. We just finished completing it, thank God. And that included patients who are ANCA-negative. So we're looking at it. It's a good question. And I think we need to be thinking broadly, because the patient has something who's in front of you. Is that a follow-up to this, or is it, okay.
It's supposed to.
Oh, that's the immunologist.
Yeah, it's actually most of the patients after Rituximab became ANCA-negative. That is because the biological action of Rituximab, it kills the B cells. That are those that produce the ANCA, not all of them, but a few of them. So usually most of the patients become ANCA-negative, which is a good sign, because actually if you takes out the antibody, then the disease shouldn't come back. Not in all, yeah, okay. Not in all the cases, let me finish. Not in all the cases and not in all the patients, but usually physicians are very happy when they see that after a Rituximab patient become ANCA-negative because of that.
Do you still
repeat the question.
So the question is, if the disease come back, ANCA comes back, right? As that's more or less, ANCA is it's not in all the cases, but in most of the cases, B cells and ANCA, if you are ANCA positive from the beginning, because not all of the GPA patients are ANCA positive, but if you are ANCA positive at the beginning, it's supposed the disease come back after the B cells and the ANCA comes back. This is true 90% of the cases, and it's true in all the severe cases. There are few cases anyway in which the disease could come back. This is especially true for non-severe relapse. And it's an option. It could happen. And it could happen because, as Peter Macker was saying before, sometimes B cells are still in the tissue. Rituximab is good at killing the B cells, the circulating B cells, and we have proof now that there are some B cells in the tissue. And then if we do not deplete the B cells in the tissue, they may still produce ANCA and being able to induce the disease locally. But you can't measure ANCA in the blood.
I would just agree with most of that. ANCA is not be-all and end-all. We've been studying it for 30 years. We're very intrigued by it. It's not a marker that should make or break your decision-making for the patient in front of you. ANCA patients can become ANCA positive again and not have disease relapse. You can have a disease relapse and your ANCA does not come back, I think, even with severe disease sometimes. It's a piece of evidence. It's not that strong. We've really wanted it to be, and we just can't make it so because we want it to be. Probably in combination with this and that and the other thing, it tells you something about what's going on. But it is not everything. And so it's not a marker that we say, oh, we're going to treat you that way. Some people might say that. We've never proven that. And we know that patients' ANCA can get positive again, and it takes years before they relapse, or they might not be ANCA positive and they're going to relapse. So I think we have to be careful about all of these sort of absolutes. So I would agree. But Rituximab gets rid of stuff.
I just have a comment first based on your last statements. Was diagnosed 23 years ago, and I've been ANCA positive the whole time, and I'm doing fine. I'm off my GPA meds. So.
Great.
Anyway, my question is, when I first started coming back in the aughts, they would tell us that in 70% of GPA patients, the disease would eventually go to the kidneys. And I'm hoping that is old research that's no longer.
Let me clarify. I think all comers, 70% of patients will have kidney involvement. That doesn't mean that if you don't have it at the beginning, you have a 70% chance of having it later. As a matter of fact, if you don't have it in the beginning, the chance of you having kidney involvement later, it's not zero by any means. It's an interesting, couldn't give you exact number, but it's not 70%. It's much less than 70%. But if you had it to begin with, but you definitely have no kidney disease up front and relapse with kidney disease better. I'd say 23 years is a good start, and it's darn good that you've had it. The longer you go, this is my feeling, somewhat from data, and I think we'll see. The longer you go without a relapse, more likely it is you're going to go longer without a relapse. That's sort of basic probability theory. But you should still be checked. You should still follow.
Oh, yeah.
23 is pretty long. There's a subset of patients who never relapse, and you want to join that club.
Well,
but if you don't join that club, you can go and it can be years later.
okay.
But it's a good club to be in.
Yeah.
My question is, what are the long-term effects of rituximab on young adults?
You mean efficacy or?
No, side effects over years.
Oh, side
Like
effects.
starting at a young age, because I noticed a lot of the studies are individuals who are much older than young adults, and so wondering studies and the long-term effects of that.
Okay, rituximab, let's start by saying that it's usually much safer than other drugs, thanks God. And if we use rituximab repeatedly, let's put that way, to keep the disease away, so maintenance treatment, well, it might happen sometimes that the immunoglobulin, which are the antibody that protect us from infection, start to go lower and lower In the long term, you might become hypogamma-globulinic, which means that your immunoglobulin, your defense are low. And so that's why usually we don't go with rituximab for all lifelong. At least the evidence now is not to keep going, and keep going. It's more you do 2 to 4 years. That's what the guidelines suggest. And then you see on individual basis if it's better to keep going or if it's better to reduce the interval, or if it's better to stop it. And so it's very individual based. But I believe that the infectious risk is probably the one that I would mention in this sense. I don't know if you have something to...
Yeah, a couple of points. Number one is we certainly have young adults in the trials. It's that when you look at the tables, you see the average age is 50s and 60s. That's an average age. We certainly have people who are young who are in the trials. But this disease is more likely to present in the 40s, 50s, and 60s than it is in the teens and the 20s. So there's a full spectrum of people who are studied. And actually, I would point, there's a nice poster out here. We have our data, Dr. Bloom led on this, about age at onset and what that means. So I would have you look at that. The younger you are, hopefully, the longer you have left to live in your life. And repeated use over years, I agree. It's about infection risk. It's about vaccine response, because the vaccine response goes down not just for COVID, but for all of our vaccines. And what is the downside of long-term use? Well, you have to weigh that against what's the downside of having GPA come back over and over again. It's not good. And so we balance that. What else can we do to prevent that? First of all, you can give people a drug holiday and you sort of stop and see what happens. Sometimes it goes for a while. We're not great at predicting. We say you're likely to relapse, but that relapse could be in 6 months or in 12 months or in 36 months. And you say, well, 36 months off medications sounds pretty good. I'm going to watch carefully. I'll jump on top of it. It depends on who you are, where you are in life, what your risk tolerance is. Someone whose kidney function is pretty bad, and any more hit would put them on dialysis. You don't want to take that risk. Someone who's doing very well young, wants to start a family, have other issues, different thing. So that's why you have to have that conversation. What else are we doing to think about this? There's a drug called Rituximab I wanted to mention. You may have heard about it. It's another drug that kills the B cells. We're testing at 3 centers at Penn and at Mayo and MGH. We're working together soon to open a study to look at that. We've published on it ourselves. We've used it for people who are allergic to Ritux. Denser B-cell depletion, maybe that does more, it goes deeper, longer. We need to prove that. We're going to not necessarily prove it with this next study. It's a smaller study. How many people here have heard of CAR T cells? Right, so these are interesting ways to treat leukemia and lymphoma. We actually this is a huge area now, and actually started it with my colleagues at Penn, not me, but on oncology. We're looking into it maybe for certain people with vasculitis, could reset the immune system, and then long-term not have these problems. These are happy issues. Let's find, rituximab, is it good? It's really good. Does it have problems? You bet. Can we maybe do better? Sure. But let's figure that out.
Thank you.
I just want to ask a quick question. This thing's really low. First of all, I was diagnosed in 1991 when I was 19 years old. And so, I'm going to go old school here. I've been on prednisone, up and down for many, many years. And it wasn't until probably like the VF Foundation, really, like some speakers, that I learned about prednisone. And I'm curious your thoughts on, I need to be on a little bit, but I didn't know that 5 or under or so, the safe dosages of prednisone. And for maybe there's lots of people in the room that aren't aware of that too, of just, it's not a great drug, but if you could be on lower, right? Your
question, what do we think about chronic low-dose use, low-dose prednisone?
Yes, okay. Versus 10 to 60 or whatever, right, that people go on. Thank you.
Well, the answer is the less the better, of course. So, of course, as you were mentioning, corticosteroids, chronic use of corticosteroids increase the cumulative dose, and the cumulative dose is linked to a lot of complications, osteoporosis, hypertension, cardiovascular diseases in general, so diabetes, it's better to try to stay with a lower dose, but the EULAR, the European Rheumatology Society, and I believe also ACR, put as 7.5 per day as a cutoff dose for the chronic use that it should be better to respect in order to avoid too many complications. It doesn't mean that 5 milligrams do not have complication, but it's still better to stay lower than 7.5. Then there are, the issue is always the same. So could we not use glucocorticoids, but what's the risk of not using glucocorticoids and then having the disease coming back? So it always needs to be balanced in an individual basis. At the moment, that's at least the clinical practice. So trying to reduce the dose until the lower efficacy dose and possibly stopping it when possible. But it's mobile can work. It depends why are you using glucocorticoids. So I believe you are speaking such because glucocorticoids was used for arthralgia, I guess, or myalgia. So it means because you have, you or anybody, joint pain. So that's not maybe the only use that we do, because we use glucocorticoids that have a broad effects to keep the whole disease in remission, not just having like some kind of symptom relief. So I would say that it's the clinical practice try to reduce the dose as much as possible for that patient. There are also some other complications that could be linked to withdrawing the glucocorticoids after many years of use. But I don't want to go into detail maybe right now. What we do, what it has been clearly demonstrated right now is for the induction. So for the first phase of the disease, it's shown that you can use less glucocorticoids and you can be effective in the same way than using more. Okay, so the same effect in average. But then it's not so well demonstrated yet that withdrawing glucocorticoids, it's possible, or reducing too much glucocorticoids is possible during the follow-up. The tendency and the clinical practice is different also by center, but anyway, our tendency in general is try to use the less that we could to avoid complication.
Yeah, I think that what I like to say is the dirty little secret, one of them, in rheumatology and autoimmune disease is some patients need low-dose corticoids a long time. There are data published, Mike George and others in our center, not me, but there's data that support the idea that even at 5 milligrams, it may not be great over time, that patients overall might get more infections, 5, 7.5 more than 5, 10's more than 7.5. However, you have to balance that against the quality of life issues that happen with being. Some people just need 5 to maintain comfort. That's okay. We measure your bone density. You may work on your bones, et cetera. So it's not the worst thing in the world. Is there a safe dose? I don't think I would do it that way. It's a range of risk. We're trying to get rid of it. Does it really prevent big flares? We don't know. We just finished a trial on that called the TAPER trial, and I'll have an answer for that in about 6 to 9 months, I think. And so, you know, it took us a long time to do that. So this is an area of intense study. But I think, again, it depends on who you are, right? For some people, 7.5 milligrams of prednisone is a lot. They keep gaining weight. They have problems. For other people, it's not as much. So you have to sort of work it out. I want to keep Dr. Stein in the conversation, and I'm going to throw a question or two to you. Can you, I know you're a laryngologist, but you know about the upper airway as well. Maybe tell people a little bit about, you know, not just warning signs, but what people do a lot of rinses, people do a lot of things for their airway, upper and lower. Can you tell us sort of healthy practices that people who have had what we call damage, their airway's just never the same, so they always have some chronic cresting and some chronic problems and coughing up and stuff. What can they do? And there's lots of stuff. What do you recommend, and what's sort of the range of stuff that people can do?
Okay, so more focusing on like sinonasal issues?
Sinonasal, but also larynx. We like the larynx.
Yeah. Yeah, so something I was saying before, you know, because as Dr. Merkel showed at the beginning, you know, GPA involves so many different organ systems, and including within ENT, it can involve the nose and the sinonasal cavity, it can involve the ears and the mastoid bone, and then it can involve the upper airway and then the lower airway down into the lung. So sometimes, you know, a patient that sees me, they'll sometimes also see our otologist, for example, if they have like chronic middle ear effusions or mastoid infections. Sometimes they've needed ear tubes in the past to drain middle ear fluid and things like that. Or they've even needed surgery where you go through and do what's called a mastoidectomy to clear out any infection in the mastoid bone. Or people will have sinonasal issues, and they'll have chronic sinusitis, nasal obstruction, epistaxis, all those kinds of things. So it's always sort of funny when, yeah, sometimes I'll have a patient that sees me, and then they see our rhinologist that focuses on the nose and the sinus, and our otologist that focuses on the ears. But to answer the question, I mean, some simple things, it depends on what the person's history has been over time. Like, if the patient has required sinus surgery in the past, and they haven't been seen for a while, and they're having issues with chronic nasal obstruction or epistaxis, then, you know, just like we talked about before, it's important to see that physician back that maybe did your sinus surgery or established with a new ENT doctor, because a lot of times people will get recurrent significant crusting in the nasal cavity, and sometimes that just has to be removed in clinic to sort of reset things, and then you can go back to doing sort of like standard regimens for the nose, which often includes like sinonasal rinses. The common one that we recommend is something called Neilmed. It's basically like a bottle, and you put saltwater packets in it, and you basically rinse through one nostril and that comes out the other, and then go the other direction. And then usually people will use steroid nasal sprays on top of that. So those are sort of like the generic, you know, chronic treatments for underlying chronic sinus disease.
So I just want to make it clear that at some of our major medical centers, such as his and ours, so I've got ENTs, doctors near me who just work on the ear and hearing and the ears, and some who just work on the sinus and the nose, some that just work on larynx. We got the right eyebrow person, the left. No, we realize that most people actually don't have that, and you have, if you're lucky, an ENT doctor in your community, and she or he has heard of this, and maybe they can handle things. And this, again, there are times when a general ENT surgeon can do some of this in the office, and there are times you'll want to be seen by a more specialized place. And so it's easy for us to sit up here, we're at the big medical centers, and say you should do that, but that's not always super practical. So, you know, it's about balance. I think we'll take one more question, since you're standing up and ready to ask. Unless you're going to sing for us, which is also good.
To keep Dr. Stein back in the conversation, I have a question on, I personally started my journey with GPA with sinus involvement, and my ears were ringing and hurting really bad, and my hair, and I still have like some clearing of the throat and stuff. Like, I guess, what are the early signs of subglottic or tracheal stenosis that I may not know that I have, that maybe we can just talk about it and see if...
Yeah, that's a really good question. So, you know, like Dr. Merkel said before, a lot of times people will present with sinonasal issues or with subglottic stenosis. You know, there'll be a single organ that they're presenting with, but then later down the line, they start developing other symptoms. Some of the common things, you know, if you're developing a subglottic stenosis, are sometimes it can be as simple as feeling like there's more mucus in your throat. Now, that is a very common, you know, generic thing that a lot of people sense, and the vast majority of the time, there's not going to be a subglottic stenosis, but that can be one thing that people can develop. And the rationale behind that is, you know, the airway, I always kind of liken it to plumbing, basically. So it's just like a tube. And so if
you're a plumber?
To some degree. And so basically, if you get a narrowing at one portion, that it's like a speed bump in the road. And so the mucus that's produced in the lungs, it kind of beats its way. There's cilia that beats that mucus up into the throat, and then you swallow it. If you have a little speed bump there, some of that'll get trapped, and you'll feel like you can't clear your mucus out. And so some people, that'll be like the first sign that things are coming back, and then certainly, or developing if they haven't had that before. And then certainly as things progress, the person will start to experience shortness of breath. So usually, let's say they're a runner, it'll be first with some of their runs, then it'll be some with, you know, longer walks, and then just going upstairs. And then I can't get out of bed would be obviously the worst that something could progress to. And then sometimes people make a noisy sound with breathing, what we call stridor. It's like, that's when things are getting pretty severe. So hopefully you would have seen someone before that time. But that hopefully answers your question, kind of brings some of the initial, you know, indications. But But the big thing is you just, especially if you have a systemic condition like GPA and you start developing some symptom, it never hurts just to see someone. I see a lot of people where I just kind of talk to them, I get their whole history. I say, what I need to do is just make sure you don't have a stenosis, and we can rule that out basically in clinic where we look with a camera that goes through the nose and we can evaluate down to the voice box. Some people with their anatomy, we can see through the vocal folds and almost all the way down to where their lungs take off. Other people, we sometimes have to numb further the vocal folds, and then we can pass the camera through and see the whole airway. And then, like I said, other people, we just get a CT scan on and make sure there's no stenosis. But it's usually a pretty straightforward thing to at least rule out. And then even if you are having some symptoms of like increased mucus or throat clearing or whatever, we can rule out that, okay, it's not a structural stenosis. And then you start to focus on other common things like reflux or drainage from the nose and other things that can contribute. But what you always want to make sure is it's not something potentially more sinister that's at work. So I always try to give people a lot of reassurance. They come in and maybe I don't see a structural narrow. I try to say this is a positive thing because yes, you have this bothersome symptom, but at least it's not, this, narrowing of the airway, even though I can help them with that issue.
So I don't think we want to end with the last sentence, including the word sinister. So I'm going to say that if you're having a problem, let somebody know, because if you think something's off, maybe something's off. So this stuff's complicated. I hope this was helpful and you learned some more. And let's everybody stay healthy. Thanks to my colleagues.
Thank you.
Thank you. Thank you.